Hello, I'm Dr. Julia Price. I'm a board-certified oral and maxillofacial pathologist, and I'm going to be showing how to do a proper head and neck oral cancer screening today. You should be doing this with your patients at every visit, even if it's just a 6-month recall limited exam. Before we begin the head and neck exam, I always start by introducing myself and explaining exactly what I'll be doing. I let the patient know that this is a thorough oral cancer screening, which includes not only looking inside the mouth, but also feeling along the sides of the neck and the muscles of mastication. Patients don't like surprises, especially when it comes to palpation, so setting expectations up front is very important. Throughout the entire exam, I'm also assessing the patient's overall disposition. I make sure that they are alert, comfortable, and aware of what I'm doing at each step. I also briefly observe the eyes for any signs of inflammation, which can sometimes correlate with oral inflammatory conditions. I begin by evaluating the patient's face, looking for any pigmented, ulcerated, or scaly lesions. Really anything that may warrant referral to dermatology. I pay close attention to the vermilion border of the lips, as this is a common site for sun damage. I look for irregularities in this area and often take this as an opportunity to educate my patients on the importance of SPF lip balm. I perform my exam in a consistent circular pattern every time. This is your own system, your own order, but consistency helps ensure you don't miss anything. I typically start on the patient's right side. I examine the ear and the area behind the ear, looking for any scaly lesions, pigmented areas, or masses. I then have the patient turn their head slightly and palpate along the sternocleidomastoid muscle. Using this as a landmark to assess the cervical lymph nodes, I continue down the side of the neck and into the submandibular region, evaluating both lymph nodes as well as the submandibular gland. I then move to the patient's left side and repeat the same process, examining the ear and palpating along the sternocleidomastoid muscle for any lymphadenopathy. Next, with the patient facing forward, I palpate the thyroid gland on either side of the Adam's apple, assessing for any nodules or asymmetry. I also ask the patient to swallow for symmetric movement. Any asymmetry would be concerning. After completing this anterior neck exam, I move behind the patient and ask them to clench so I can palpate the temporalis and masseter muscles, evaluating for tenderness or abnormalities. I next assess the TMJ, the temporal mandibular joint, by placing my fingers just anterior to the ears. I have the patient open and close, feeling for any clicking or popping, and I observe their jaw movement. I'm checking for any deviation to one side. As I do this, I also ask the patient if they have any pain. Mild soreness is normal, but severe pain is concerning. Before continuing on to the intraoral exam, I change my gloves. This is an important step to me as I don't want to transfer the patient's facial oils into their mouth. Once I've changed my gloves, I begin intraorally with the lips. I palpate both the upper and lower lips, extraorally and intraorally, feeling for any masses or irregularities. I then evert the lips and examine the labial mucosa. Using a mirror, I retract the cheek and evaluate the buccal mucosa. At the same time, I'm palpating the parotid gland extraorally and I'm observing salivary flow from the Stenson's duct near the maxillary molars. I then examine the vestibules of both arches, as well as the gingiva, the facial, lingual, buccal, and palatal, moving in a systematic circular fashion. Next, I evaluate the oral pharynx. I ask the patient to stick their tongue out and say ah, and I use my mirror to gently depress the posterior tongue for better visualization. Also examine and palpate the palate, paying close attention to the lateral regions as this is a common site for salivary gland tumors. I then move to the floor of the mouth and I perform bimanual palpation, placing one hand under the patient's chin and one finger intraorally. I assess the sublingual gland and evaluate for any masses or induration. I also visually inspect for red or white lesions, keeping in mind that this is a high-risk site for oral cancer. Drying this area can improve visualization. Next, I evaluate the tongue. I have the patient stick their tongue out and then gently grasp it with gauze and ask them to relax. This allows for better mobility as I move the tongue side to side. I examine and palpate the lateral borders, especially posteriorly, as well as the dorsal and ventral surfaces. I'm looking for any lesions, color changes, or masses. Drying the tongue helps to minimize distortion from saliva. After releasing the tongue, I inspect the tip separately, since it was not fully visualized while covered by gauze. I then ask the patient to place their tongue to the roof of their mouth to better evaluate the ventral surfaces. This completes my standard oral cancer screening as part of my head and neck exam, And at this point, I go over any findings with my patient. I also like to take intraoral pictures so that I can show it to them.